Welcome back to the Spoken D podcast with Dr. Walt Duffy and Matt Duffy. Hi, Matt.
Hello.
I think today we had thought about a couple of topics, but we landed on one, and that is, we believe in integrated patient care, correct?
Yep.
And I know for ourselves, we initially started offering behavioral health, but now we have on our site behavioral health, on-site pharmacy, primary care, research, some other things that we do. And one thing that has been brought up is that outside providers that are doing like primary care, would there be a concern of referring to a place like us who has a mission of doing behavioral health integrated care?
Yeah, both. We'll focus more on the primary care to behavioral health or integrated practice, but some of this overlaps regardless of reasons for referral between clinics. Right? It's lots of things impact when referrals happen, why they may not happen, and we're going to touch on a few of those today and maybe take a little bit more opposing sides than on some topics to see where we go.
That makes it a little bit more fun anyway, right? So I think, when I first came to town, we came up with a name of that was purely behavioral health related.
Yep.
We had nothing else to do, and that's all we offered. So at that time, receiving referrals from primary care physicians was not a big deal, and I'm adult and child psychiatrist, and so folks like pediatricians and those things, because they didn't have to worry about me doing their primary care, right?
Yep.
For their patients. And I think also we know what's really interesting is if you look like at the antidepressant market, if you look at the volume of who does the most prescriptions for antidepressants, is it the psychiatrist?
Nope.
Yeah, so it's actually primary care, correct?
Yep.
So we know that, thankfully, primary care, internal medicine, a lot of these specialties, pediatrics, do a lot of behavioral health medication management.
Yep.
And I think you've sort of were telling me some numbers recently where those numbers have even grown some as far as a percentage of at least a part of each visit and how many visits they might have over time on a clinic's patients panel.
Yeah, just real high preliminary data, and it's probably depends on how you read it, right? Depending on what you're looking for. But over, I think, 2022, the data was of the population that was looked at, roughly 70% of visits that are seen in primary care have some type of mental health coding within the visit.
So they might have a diagnosis listed of depression or anxiety. It might not necessarily be fully addressed that, but that's one of the things they have been addressing, right?
Yeah, so I assume that means in the ongoing care of the patient, that provider's handling that condition. Or at least
handling,
it's
or that's part of their integrated care, whether they're have referred that out, but it's still part of something that they talk with the patient about during that time. Yeah. Yes.
And then the most recent data I could find was 2018. So with how much mental health has grown the past 4 years in terms of demand, I'd assume it's increased. But in 2018, the data, primary care had increased to taking care of somewhere between 15 to 20% of their visits were only addressing mental health.
Okay.
So primary care is taking on a larger burden of the mental health population and seeing it be a larger part of their daily patient base, needing to help with those concerns.
So one of the devil advocate things that you were bringing up, because I'd like to address all these actually, is from just a business person's financial thing of trying to run a practice and make it so that you're not losing money. Mm-hmm. You're talking at least 20% of primary care visits might just be solely behavioral health oriented, right?
Yeah, so if we look at So coming from either a consumer standpoint or a business standpoint, right? Why is a reason that you may not get referred, or a concern of why you may not get referred? Because this is talked about on a larger landscape of healthcare in general by the concern of the patient is, well, I'm just a number, I'm just a financial metric, right?
Uh-huh.
So it exists because of how healthcare works and it being a business, but not just from the referral standpoint, but patient concern also. But if just flat numbers, you're looking and saying, why would someone not get referred onto specialized care, right? Well, it's hard not to look and say, well, if 20% of a provider's income is directly related to a disease state like mental health, if they were to refer all of that out of their clinic, that is, quote unquote, referring 20% of their income out of the clinic. And where I think the concern from patients is where does the line get drawn between I'm your income versus I'm someone who needs health care, right? And on an individual basis, it's easy to talk about, well, any one individual patient's not impactful to the grand scheme of income, but large percentages of entire patient bases or where your income comes from on a large scale, that becomes a different concern looking at it, right? If primary care was just to overnight say, or if the government was to come and say, it's no longer in your scope of practice, you cannot prescribe those meds, you have to refer them on to a mental health provider. And that's 20% of their daily visits that are gone and the income associated with that.
Yeah, well, but let's look at that from both provider and patient perspective. So we know there are not enough behavioral health med management providers out there to see all the patients, right?
Correct.
So to see all the
so
patients.
It's impossible to refer it on it.
Yeah, you
right?
can try, and you already hear in cities 3-month waits, 4-month waits, 6-month waits. Some providers only take certain insurance, so and they have limited availability, right? So I think we really depend on primary care as behavioral health providers to take care of all those folks who might do well with their first medication or 1 or 2 medicines, and and that's good. I think and from my perspective, I want to be able to use my services for the people who are more in need that didn't respond to the first medicine or the second medicine, because we sort of specialize in some of that treatment-resistant population. And I think that's where we really provide a big niche and help to both the provider and the patient. So what I see from my perspective is, because we have people referred by themselves, by the patient, family and friends, and providers, whether that's a therapist, a primary care provider, a specialist provider, like that they're seeing, like somebody has sleep apnea, but they have a lot of anxiety, so they can't wear their CPAP. So when I see the patients that are referred, it's great when they're referred by their primary care provider for specific things, whether that's transcranial magnetic stimulation or ketamine, and please just take care of this. Or I've tried a couple meds, can you please take care of their med management for this? Because I have built-in integrated care. They have a great relationship with their primary care provider, and that I can send documentation to, and we're able to help out on the medication management side or these other service lines that we provide. It is more when the patients come in that they have not been referred by their primary care provider, or they're referred by family and friends, and they're wondering, I was just left out there sort of in the defend for myself. Nobody referred me, so why wasn't I referred? If it would have been a heart issue, I would have been referred to the cardiologist, right? That's something you can just take care of with an easy antihypertensive, and you did that. If I broke my leg, you probably would have referred me over to the orthopedist. So we like it when they have those great relationships with their primary care provider because they're more likely then to follow up for their behavior health management too. So one thing that I know that we have struggled with a little bit is the perception that when we added primary care to our clinic, that we were maybe going to take away patients from their own primary care providers if they got referred for behavioral health. That really makes not good patient care sense, and it makes no good business sense, and it just doesn't create a good care experience. So we opened up a primary care part of our division of our clinic because so many patients that have behavioral health needs either don't have a primary care provider, or if they did, they have never seen that primary care provider. They'll say, "Oh, I have a primary care provider," but they didn't see them like in 3 years or something. They really they don't follow up with their primary care provider, and that's what we provided so we can provide that integrated care for those folks who don't. But we love it when we're able to provide the higher level services for people who are more like treatment resistant while they can still maintain their own primary care provider out in the community. Because we could not provide primary care services to everybody who needs them either. That you just can't do that.
Mm-hmm.
So,
yeah. So the one I think you're touching on what I think causes the concern of, at least from the patient perspective, of, well, I'm just a financial number, right? Because it's, okay, we can address the referring for behavioral health, not a big issue because they're still going to see you for their primary care. They're still going to have that income, right? But if you refer for behavioral health and as a patient I convert into their primary care and don't come back to you, why do you care? The only reason I can think of is you're concerned that you don't get my money anymore. So now you're basing your referrals on, are you going to keep getting money from me, and not necessarily what's best for me, right? Because why else as a provider are you concerned if I'm stolen?
well, no,
Right?
I don't see it. I don't really see it that way because as your provider, say I've been seeing you for 5 years,
Mm-hmm.
okay? So I know you pretty darn well. So I feel like our clinic provides good primary care services for you. You're going to go over there. I don't know. I can't tell you they provide the same quality of primary care.
Mm-hmm.
I know that we can work with we've done this for years. Anybody who's been out in the world, it has been very common over many, many years and many generations for primary care providers and behavioral health care providers to work in tandem.
Mm-hmm.
When you go to the cardiologist, I'm still your primary care provider,
Mm-hmm.
taking care of those needs. So I'm sending you to a specialist because you've gotten past where I feel comfortable. And that's what I often see, actually, when we get the referrals from our primary care colleagues is that, hey, we've tried a couple things, but I'm past my point of comfort in that area, my expertise in that area. So, we're going to get you extra expertise for that specific area, and that is showing I care a lot about your situation. So I would hope in that conversation that you respect that I, as your primary care provider, want to keep you as that primary care.
Mm-hmm.
Yeah, so you're not a number to me at all. It's just that I'm still that coordinator of your care.
Mm-hmm. Yeah, so it's hopefully more of a perception than a reality, right? But it's maybe the easiest thing to point at because we're not necessarily talking about some of the other reasons that impact why people switch their care or choose to stay in care. And one we've talked about is, do I feel like my provider had my best interest in mind? Right? You touched on that. I had to refer myself. The provider never told me I should go. Are they the right provider for me if they're not fully taking care of me?
Yeah, but we've also, that's just interesting, folks. We've also talked about that and we talk about this all the time, there's still a stigma to mental health. Mm-hmm. So I can tell you, even with the patients that I see that come into me specifically for behavioral health. You know how easy it is to come into a provider. As a patient, and I do that, and I've done this myself as a patient, to the provider, I want to come off in a good light.
Mm-hmm.
I want to tell you that I'm doing pretty well. I might be feeling crappy. So, and I've told you this type of story many times. So, folks who have pretty treatment-resistant depression and they've gotten better, and we got them to they were in remission, and then we're seeing them over time and following them, and they come in one day, and I can tell that they are not doing well just by how they look, how they carry themselves down the hall, how they're looking at me. But everybody, all the providers out there know what a PHQ-9 is. It's a measurement of depression, right? Mm-hmm. On that scale, they've circled all zeros or ones. And they're in the appointment, they say, Doc, everything's going fine. Mm-hmm. And I let them talk, and I said, Mary, I don't think you're doing, I'm sorry, I don't think you're doing fine. Oh, well, to tell you the truth. Mm-hmm. And if you look at appointments out there, and this is just the way with the way insurance is, and you have a primary care provider who might have 7 problems to go through. They got 15 minutes to go through those 7 problems.
Yeah.
They're not trying to avoid, but what are your top priorities? I got maybe, we all know 2 or 3 things is the max you can take care of, right? So they're trying. Right. Yeah, at a time. So they're trying. So I think it's everybody's perception. Everybody's trying to do the best. And the other thing we've talked about is doing okay versus being in remission. Mm-hmm. Right? So we know with psychiatric diagnoses, treating to remission gives a much different functional outcome than treating to doing okay. Mm-hmm. And also the risk for relapse of issues. But it's taken sort of, a lot of times it's when I have to get through all these things, or you're doing okay. Mm-hmm. And we don't have these numbers in a lot of psychiatry that, you have the hemoglobin A1C for diabetes. Mm-hmm. I got to keep it under a certain number, right? So I have a number in front of me. So the PHQ-9 sort of gives you that for depression, but that's a snapshot in time. Hemoglobin 1C might be over the last month or so. Mm-hmm. This is today. How did you score, right? So it's a lot more complicated than people think.
Yeah. I think what you're touching on is what providers are more concerned about, right? Which is, it's real important for you to have a trusting relationship with the patient, right? That you have to have a sense of trust.
I think most of us go into this profession because we like to talk to people. We like to deal with people. We hope that we are developing a sense of trust. Mm-hmm. And we know in today's society it is so easy to lose that perception of trust.
Yeah, and if the trust is lost, then the patient may not go anywhere for healthcare, right? So keeping them engaged in healthcare is the number one priority sometimes, so that they're at least getting something.
Yeah, so one of the things on my end, because I respect my colleagues, I think they do a lot of excellent work in all this area, and they've put in a lot of hard work. So if somebody's been seeing a provider for quite some time, I want them to try to stay with that provider. Mm-hmm. It's very difficult to develop those types of relationships. And we're so quick to one thing didn't get addressed or got missed or, I need to go see somebody else. Really? How long have you known Dr. Jones or whatever, and they've been treating you and taking care of this? I think we should continue to work here. I think, we often do that in behavioral health with therapists. Mm-hmm. I've been going to that therapist, and I just don't think they're the right person for me. We just haven't gelled. How many sessions have you been? Once. Well, I've been 5 sessions. Well, did you bring up that you had any concerns that you might want things to be addressed a different way? Well, no. well, okay, well,
Hmm.
can we go back and address with the therapist that maybe there's a different way? So you we're not mind readers, right? I don't care
Hmm.
what profession we're in. We're not mind readers. So we are. It's a partnership between the patient
Hmm.
and the doc, and also between myself and your primary care provider, and all of us working together. So I think it's working on that team approach. And to me, integrated care is much more than just our clinic.
Right.
You know, we have the whether it's referring to pulmonary because somebody has sleep apnea and we need sleep studies done, uh, or our folks are we find out that their labs that we're running because of they're on various meds and their lipids are high. We need them to go back and follow up with their primary care provider, or they don't have a primary care provider, and we're able to serve that within our own clinic. I mean,
Hmm.
those are all forms of integrated care. So behavioral health integration is not a silo within one practice or one group. If you're really going after that holy grail,
Hmm.
then you're more concerned about how do you work within that community environment and keep everybody moving
Hmm.
forward. And you'll do fine both serving patients and doing other things. So that's one reason we sort of train students
Yeah.
because they're going to go out and hopefully they'll have some behavioral health knowledge to help. Most of them end up in primary care, folks.
Hmm.
You know, we've trained over about 1,000 students actually,
Yeah.
and they've gone out and we're probably 90% of them are probably started out in primary care. So, uh, so hopefully we've done some good in that area.
Hmm.
Don't always know, but so I think integrated care is a much larger picture than just looking at a little clinic.
Hmm. Yeah. I think the one for the in the trust model, right? That we don't really know where the line is, and I think because of that, providers are sometimes overly cautious because we even deal with it uh, with our providers and patient population, even for internal services. You know, when do we refer? And it's the concern of if I refer you, and either you're not ready to hear it, or you have a bad experience with it, and now you look less of me as a provider, right? Oh, can I really trust you? You really know what I need? And then you start to question, well, should I still come see you? Do I really need care? Does anybody out there really want to help me?
Yeah,
Right? So that's sometimes a barrier to physicians, I think, referring between each other is, am I setting up my patient for an experience that's poor, or are they ready for the experience, and is it going to hinder my relationship and my ability to take care of them because something external to me happens?
yeah, that's I understand that. And it was interesting when I came to like our town in 1998. I was board certified in child and adult psychiatry. I thought, well, they have very few child psychiatrists. That will just those numbers will my panel will fill up very quickly for that. And it was very interesting because I got to town and I found that it was very slow going to get child and adolescent patients because the pediatrician offices and we're, you know, there's a new person in town. We don't really know them. You know, we not only have our patient, we have their parents. And if they have a bad experience, who's going to hear about it? It's just like if you work with a vendor, right? Who's going to hear about it? I'm going to hear about it as the provider who referred them. And now I'm going to have to deal with that mess. So um, that is, and then you're a new provider in town,
Hmm.
and you don't necessarily know the people who are out there. So that does take a while. So that is understandable. And you already might have dealing with somebody who's feeling very depressed or anxious, and they're already, you know, having some issues, and you're wondering how that handoff is going to go.
Hmm.
And when they come back to the clinic, are you going to have that first patient note back that they had? So that is a valid concern for providers out there to have, but you can only test those waters. Just like if I send somebody to a different primary care provider or to a pediatrician or to the cardiologist or that, you only find out over time, and then you have to have enough. Just like trying a new medicine, you have to have done enough referrals back and forth to develop a relationship, so you're able to figure that out.
Yeah. Then the last one we were going to touch on, as we just pull back the curtain a little bit for those who don't work in healthcare, that is another concern in the business model, right? Maybe less so for providers, but within the business model of healthcare, is we have more restrictions than other industries, right? So we can't strike up deals with other offices and say, oh, if you do this, then we'll do this. And if you do this, then the quid pro quos, so to speak. So there's no guarantee we can give. There's no legal agreement we can enter into that says, if we do business with your office, we will restrict your patients from our clinic, right? We can't remove patient choice from the world of what a patient wants to do.
So you're saying, like, if a patient comes in and says, I would like to use your primary care. I want all my care in one spot.
So they're referred for behavioral health. Our intention is you're with your primary care provider. It's going great. Why would you ever change? And the patient is making a choice. And there's very minimal restrictions you can do around giving patients control over their health care.
Yeah. I would just tell you my experience, and my experience will speak to around 30 years in healthcare, and I've been in Lincoln since 1998. So my experience is that when a patient has a good relationship with their primary care provider or their specialist, and they're referred in, whether it's to take care of all their behavioral health management or to do some of our specialized services, the patients are so connected to their primary care provider, that conversation never comes up, because I'm not going to bring it up. You already have somebody referred you, why would I don't want to hurt their relationship, and you have a good relationship. Why would I mean, from a mental health perspective, why would I tarnish your relationship where you're feeling good about something? Mm-hmm. So that just makes no sense. So it's more likely, again, that the patients who come in and ask to use our own primary care is because they don't have a primary care provider. Luckily for Lincoln, more people we're seeing are moving into town from other places. So that's a great thing for where we live. And or three, they've aged out of their pediatric clinic. Mm-hmm. And now they're just they land on our doorstep as a behavioral health patient. They say, hey, by the way, I see primary care. Can I do that here too? Because now I need an adult primary care provider. Or they really at one point had seen a primary care provider and they haven't in a number of years. Mm-hmm. So they're saying, well, since I'm here, can I just do everything here? But it has been very, very rare in my experience that somebody has been referred by a primary care provider and they ask to switch. Mm-hmm. That just, people are usually pretty connected with their primary care providers.
Yeah. I think what we're more or less establishing is it's like some previous podcasts we've done, which is there's a lot of underlying assumptions and fears because it doesn't get talked about, right? When you're being referred by your provider, part of the conversation may not be, hey, I'm not guaranteeing a great experience, just if it goes a certain way, come back and make sure you talk. Or, hey, I want you to go do this, but I'm concerned that you're going to drop your care with me. They're not the easiest conversations to have, but if we don't have them, then we're making assumptions in the care. It's no better than making assumptions in how to care for someone without knowing what's going on.
Yeah, I believe that. Well, I know this for our office. It's can we get feedback if we're not providing your patients the services that you feel like we should be? We want to hear that feedback. How can we do things differently? How can we engage with your office differently, because we want those patients connected across the whole spectrum, right? Because that's going to improve their care, and that's what we're all here after. How do we? Every patient is what I call an N of one. If you think of research terms, when research studies come out, this medicine works across this whole population. Well, that's great. I'm not concerned about the whole population. When you're in my office, I'm concerned about you. Will it work for you? And that's a different way to look at things.
Yeah.
So the more I can have you that you're connected with folks that you trust and that you'll follow up with and that you'll listen to and take some of their recommendations and that will facilitate things together, that's the win for everybody, and that's what helps individual healthcare and population healthcare. So there's many ways to skin the cat, right?
Yeah.
So are you willing to, and I think you need to, if you really care about folks, and I thought about this, when we were having a conversation last night, we were talking to a potential marketing person. And when you I was thinking about this to myself, when you send back to a provider, thank you for sending a patient for me to see, it's really, that's not where I'm really thanking for you. I'm really saying, thank you for caring enough about your patient to send them for the care that they need. That's what's really important. So I just think it's an interesting topic. So if any providers have comments, they'd like to hear more things about this, we'd be happy to talk more about it. And I think we need to close things up. So thank you for tuning in to the Spoken D podcast, and we'll catch you on the next one. Bye-bye.